Good afternoon, everyone. Thank you for Despina for a bit of science. Some of that went over my head, so I hope the rest of the audience were able to follow. I just need to share my screen with you. There we go. And I also need to thank Anthea Holland and Gil for what I also thought was an absolutely inspirational and fantastic history that Anthea gave, and she said some very nice things about me, and I'm very grateful for that. I had no idea that today's meeting was planned in this way, but obviously it's nice to hear that Anthea is doing so well in times that are clearly not straightforward for anyone, whether you have CLL or you're helping to support and look after patients who have CLL, and obviously outside of the healthcare setting. So I was given this title, CLL Update in the Time of a Pandemic. Just showing you some shots there of the two main hospitals I work in, St. Bartholomew's Hospital, which is on the right of your screen, and the Royal London on the left. Just a little bit of history. So you're looking at the entrance on the right to St. Bartholomew's Hospital, the old entrance, the Henry VIII gate. And I'll come back to the history of the hospital a bit later. Because within the NHS, there are some fantastic things that we can appreciate, as well as some things that we don't always appreciate. So I'm going to touch on CLL treatment, both in the context of clinical trials and outside of clinical trials. I will speak a little bit about SARS-CoV-2 and COVID-19. Perhaps the terminology of SARS-CoV-2 is not familiar with everyone, so I'll touch on that. And I think there should be plenty of time for question and answer at the end. I'm not answering my phone, I'm just putting the timer on. Sorry. And it's not to cook an egg. Okay. So firstly, CLL treatment outside of trial for patients who need treatment for the first time. And you can see in brackets there a slightly odd phrase, without TP53 disruption. Now, I suspect some of you may be more familiar with what this means in the context of 17p deletion. So let me just say a little bit about why this is there in terms of treatment choice. So we had some really beautiful pictures from Despina, and this is about the prettiest picture I'm going to show you. We're looking at this wonderfully acronym technique, FISH, fluorescence in situ hybridization. And the purple blob you see there is a CLL cell. And inside that purple blob, you can see there are two green dots. The reason there are two green dots is these are two green probes that attach onto a specific gene that can be abnormal in patients with CLL, called ATM. Because there are two green dots, it tells us that both ATM genes found on chromosome 11 are present. Remember, we inherit our chromosomes, one from our father, one from our mother, and hence there should be two chromosome 11s, and indeed this cell has two. However, the red dot is all by itself, and the reason for that is that the red dot is a probe, a red probe, that detects the p53 gene, TP53 gene, found on chromosome 17. And unfortunately, there's only one dot. So this tells us that 117p is missing. So that's FISH technology. And you may recall that Anthea Holland told us that she had FISH tests done before she had her treatment. Now, things have evolved a little bit since Anthea first had treatment. And now this test is also required, ideally, I shouldn't say ideally, this is required before a patient starts their first treatment. And this is looking for, again, TP53 disruption, but next generation sequencing, which is nowhere near as visually attractive as FISH, is an extremely powerful technique that can detect mutations within the gene. A FISH cannot do that. So you may have a FISH test that does not show 17p deletion, but next generation sequencing may find a mutation within the gene itself. And that's the importance of doing both tests. So in patients requiring treatment for the first time who do not have a problem with their TP53 gene, I say fit, we refer to patients as being suitable for this treatment, which is chemotherapy with fludarabine and cyclophosphamide tablets, along with immunotherapy with rituximab. And I suspect most of you are familiar with rituximab being a monoclonal antibody, which does some of the things that Despina was mentioning. It sticks onto this antigen, this surface marker on CLL cells called CD20. For less fit patients, and once again, I should emphasize that we don't, and I certainly don't, define fitness in terms of age. It's really biological fitness, not chronological fitness. Then treatment available in the NHS is chlorambucil, so that's tablet chemotherapy, with obinutuzumab, so that's another monoclonal antibody that sticks onto the same marker as rituximab CD20, but is possibly slightly more effective than rituximab, although I would say the data is out on that. Now, it's probably worth mentioning that there is good data now that in both of these settings, Ibrutinib, which you've heard a little bit about today, so this is a tablet treatment, not chemotherapy, it's a targeted treatment, is good and possibly a better alternative in both settings. So for FCR eligible patients and for patients in whom we do not think FCR is appropriate. However, this is not available in the NHS as first-line treatment, except for patients who do have an abnormality of a T53 gene. And in that setting, patients can access either Ibrutinib by itself or venetoclax by itself, or alternatively, the combination of idelalisib with rituximab. Now, because of the occurrence of COVID-19, the restrictions it's placed on patient care and potentially on choices of therapy, this drug, Calibrutinib, has been made available by the company that makes it on a compassionate use basis for the first-line treatment of CLL. So really effectively, at this point in time, we do have Ibrutinib, or a drug that's very similar to Ibrutinib, it's a newer version of Ibrutinib, available as first-line treatment for patients with CLL. Like Ibrutinib, it's tablet therapy, and like Ibrutinib, it's given on an indefinite basis. Now, there are some caveats about being able to access this for patients who need this as their first-line treatment. The first is the access criteria define your age. You have to be equal to or older than 65 years of age. Now, if you're a younger patient who wanted this drug, that's obviously not very helpful. But if you're younger than 65 and you are not eligible for some reason for chemoimmunotherapy, which is what we call FCR, fludarabine, cyclophosphamide, and rituximab, then you may indeed be eligible for Calibrutinib. In fact, we were able to access a Calibrutinib for our first patient very recently at Barts Hospital, and it's quite interesting to discuss what's happened to this individual within the first week of treatment. What about patients who've had treatment and unfortunately their CLL is progressing and need further treatment? So second-line treatment and beyond, outside the context of a study. Well, this is relatively simple. We have, in fact, the same range of treatments, or very nearly the same range of treatments available in this setting, as if patients were having their first treatment but had 17p deletion or a p53 disrupted in some way. So venetoclax now is combined with rituximab in this setting, and it's a very interesting schedule because it's time restricted. So the studies that were done treated patients for 2 years, did achieve extremely good responses and stopped therapy. Now that is potentially a very attractive approach for some patients as well as healthcare systems. I should point out that in the original studies done, there's some suggestion that if patients are showing signs of progression after that treatment, they will respond again to venetoclax, which is quite an interesting possibility. Or patients can receive Ibrutinib, or patients can receive idelalisib with rituximab. I'm not really going to say much about other options, but I have not actually come across any patient recently in whom we have wished to repeat chemoimmunotherapy, be it with FCR or an alternative combination of chemotherapy and antibody drugs, having had that as their first-line treatment. But it is a potential option. And I think it's worth just pointing out that I have several patients who were treated in the early 2000s for their CLL as first-line treatment with what we would now recall as being undertreated with fludarabine and cyclophosphamide alone, who remain in long-term remission extremely well. I'm just pointing out here that we cannot predict how any one given individual will do. And while we believe that FCR is a better treatment than FC alone, I can cite a number of patients in whom they have done extremely well without the rituximab. So this will come back to a theme I'm going to talk about later, is how we make choices. What about transplantation? So this is largely not discussed in CLL anymore. There was quite a vogue for transplantation in CLL about 15 years ago. But this form of transplant, allogeneic stem cell transplantation, that's using blood stem cells from another person to give to the patient with CLL, is relevant to a very small group of patients and is potentially curative. But this is a very complex process, not suitable, in fact, for the majority of patients with CLL, and comes with a number of very potentially significant problems. In terms of CLL treatment within trials, there are, I should say, a lot of trials available, even in the setting of the current pandemic. But I'm not really going to touch in any detail on these. I will simply mention that the FLAIR study, which is a study for first-line treatment for patients who are deemed to be suitable for FCR. And the reason for that is this study originally had 4 different potential options in the study. So FCR, a standard first-line treatment for younger, fitter patients, or Ibrutinib by itself, or the combination of Ibrutinib and venetoclax. And there was a 4th arm, which is now closed, Ibrutinib with rituximab. So this study was due to close earlier this year, but in fact is still running. To find more information about first treatments in CLL, as well as other treatments further along the treatment pathway, in the context of studies, I would recommend this website, where the UK CLL Forum has got a list of studies as well as centres where they are open. What about treatment decisions in the time of a pandemic? Do we need to adjust what we would have done before the pandemic? And I think you will all be very familiar with we do need to address this. But in order to address this, I'm going to ask you a question I ask the medical students when I see them and I teach them, is, do you think medicine is an art, or do you think it is a science? It would have been lovely to have voting. I'm not sure if that would have been possible, but anyway, it's too late now for that. And a second question for you is, what would you prefer? Would you prefer if medicine was an art, or would you prefer if medicine was a science? Well, since we can't vote on it and I can't hear your opinions directly, but just a reminder, there is a question and answer facility at the bottom of your screen, then undoubtedly it's a science. There is a huge amount of data involved in the practice of medicine, but data, so as we've just heard from the talk from Despina, you can generate a huge amount of data relating to healthcare, but at the end of the day, we won't argue about the facts, we will accept the data, but it is the interpretation of the data, and from a patient perspective, the clinical implementation of that data that is important. So the data is objective, but the medicine is most definitely an art. If you only science, then I'm afraid you will, in my opinion, be internet connection. So I hope it's still reasonable for yourselves. So this is about as scientific as it gets at the moment in terms of making treatment decisions during the pandemic. So this is a recently published guidance document. The authors of this document are some of the most eminent CLL experts, particularly in Europe. And I've just summarized here what they said in their guidance, and you can decide how much this is science and how much this is art. So one of their key pieces of advice was patients should minimize exposure and the risk of exposure to the virus. I think that goes without saying. And they emphasized as part of this, avoiding hospital clinic visits as far as possible. They addressed the issue of treatment. For patients who look like that they need treatment for their CLL, their advice was don't treat. It was interesting advice. Delay therapy for as long as possible. And I was very interested in some of the detail of what they said, because they almost seem to be changing the boundaries at which we clinically start to say an individual needs treatment for their CLL. And in fact, the boundaries they were changing fit very much with my clinical practice over many years. So I will always discuss this carefully with the patient and their loved ones. And I will not rush to treatment unless it is really necessary. However, so beyond delaying therapy, if therapy needs to be started, then you can see here the drugs that they recommend. There has also been, and we've heard it as well from Anthea during her video, the question of immunoglobulin infusions. For those patients who are already on immunoglobulin infusions, what should happen during the pandemic? And interestingly, these experts did not say stop infusions, because they require the patients in general to go to hospital to have the infusions. They suggested the infusions could be given less frequently, or alternatively, given subcutaneously. And in fact, in my practice at Barts, I routinely refer patients to our immunology department, and this is pre-COVID, for consideration of subcutaneous immunoglobulin, as we cannot prescribe subcutaneous immunoglobulin from the Haematology department. We can only prescribe intravenous immunoglobulin. And just a reminder, which these experts did as well, it's seasonal flu vaccine is very important. And if you've not previously had Pneumovax, the strep pneumonia vaccine, then you should do. Okay. So one thing I haven't touched on in terms of treatment for CLL is what is often unfortunately referred to as watch and wait. Once again, I think art versus science is very important here. So in terms of the science of watch and wait, I'm pressing the wrong button, it's very simple. This isn't a very nice graph, but it's taken from the paper, the original paper in 1999. If I just orientate you along this side, we have years, and you can see the graph goes out to 10 years. And on this line, we have survival. So this is survival in % of patients with early stage CLL. And what the authors did, they looked at studies that compared early treatment for people with early stage CLL, in other words, immediate chemotherapy, versus treatment later on during the disease. They looked at 6 studies with over 2,000 patients, and you can see from here that those patients who received immediate chemotherapy upon diagnosis of their CLL, although they were in an early stage of the disease, had a slightly worse survival than patients in whom treatment was deferred. And these studies form the basis of what has long been referred to as watch and wait. Now, that's the science, and we can present that to patients when we see them. We heard Anthea herself talking about how she was first told that she had a disease of which she would not die from, but die with, and implication being this was not a serious problem to worry about. Well, I certainly wouldn't agree with that, because there is an art to this. We can present the science, but we do not address the many issues that patients have when they are told they have a very serious condition, yet you don't need treatment for it. So the words that we use are incredibly important, and I would really welcome that we move away from watch and wait. I've been trying to promote the phrase medical observation. Someone suggested to me yesterday, possibly, oh, I've forgotten the phrase, an alternative phrase, but I really do feel having a more positive phrase would be helpful. One, to reflect the science, and secondly, to reflect the fact we are not watching and waiting. Patients who are in this situation are, at least in our centre, under medical observation. We follow them up, we perform blood tests, we talk to them, they can access their clinical nurse specialist. I really do feel the idea of watch and wait is very negative and unhelpful. So moving on from treatment then to SARS-CoV-2 and COVID-19. So please forgive me if all of you are familiar with these terms. You may be, you may not be. So SARS-CoV-2, COVID-19. And SARS-CoV-2 actually stands for Severe Acute Respiratory Syndrome Coronavirus 2. And that name tells us a little bit about the virus, and I'll come back to that in a second. There is a huge amount of data. In fact, there's so much data out there. And if you bear in mind, we didn't know this virus existed until very late December of last year, 2019, then this has been an outpouring of research looking at coronavirus and SARS-CoV-2. And unfortunately, much of it is contradictory. And I would suggest it's extremely difficult to make sense of a lot of the data that's out there. One thing I can say, I keep on pressing the wrong button, sorry, because I'm trying to run two screens at the same time. Never very clever for a man to try and do two things at the same time. One thing that is reasonable to say, a summary from the data, is that patients with chronic lymphocytic leukemia, along with patients who have all forms of blood cancers, do worse than the general population if they develop serious COVID-19 infection. And perhaps unsurprisingly, those factors that predict for a worse outcome the general population also apply in this setting. So older age and male gender. And in the context of CLL being on treatment versus not being on treatment. Now, having said that, I think it's really important to understand the limitations of this data. So it is perhaps not surprising that patients with a cancer and underlying immune defects have poorer outcomes if they develop severe COVID-19 pneumonia. I don't actually think we needed too many studies to be able to know that that was likely to be the case. But all of the work that has been done on a very biased population. And what I mean by that is these are patients known to be SARS-CoV-2 positive. And the reason we know they're positive is not just because they've been tested, is because they've got to hospital unwell. You may be aware, you may not be aware, early on in the pandemic in the UK, the only people getting tested were either healthcare workers such as myself or people ill enough to present to hospital. There was virtually no testing in the community. So we are looking at a pre-selected group of patients who are already ill. This does not tell us about how patients with CLL in general do if they get SARS-CoV-2 virus. So we have no idea about the true denominator. What is the true rate of patients with CLL becoming ill if they are exposed to the virus? Just as we don't know the exact data in the general population. What we do know is people who get the SARS-CoV-2 virus, the vast majority of people are in fact not unwell. So it's just important to be aware of what the data tells us and what we don't know about SARS-CoV-2 and its effects. Okay, thank you. So this is a slide I often use as my last slide in talks that I give. And this isn't actually my last slide. The reason I put this here is, one, to just share a bit of art with you. Secondly, because this art you can find within the National Health Service, and you won't be too surprised to hear, is at St. Bartholomew's Hospital. You're not likely to be popping into central London anytime soon, but if you are, please just pop into the north wing of the hospital and look at this wonderful work by William Hogarth, depicting people with different illnesses, and supposedly he used patients who were in the hospital at the time as his models. And this is a depiction of Christ at the Pool of Bethesda, and Christ is about to perform a miracle. I've been using this painting in talks and looking at this painting for many years now. And when I was preparing this talk, I noticed for the first time, I'm surprised I hadn't noticed before, the similarity between the angel that's flying past above the Pool of Bethesda. You can see the angel is really semi-nude, and this lady here, who is also semi-nude and reclining in a very similar fashion to the pose of the angel. I can't help feeling that Hogarth was trying to make some social commentary here, as he did in many of his drawings and paintings. This lady here is supposed to be a high-class prostitute of the time. And the other reason I wanted to introduce this slide at this stage is because what follows is very much my opinion. I think most of what I've said so far could be regarded as fact, as science, with a bit of art thrown in. And this is very much how I look at the current problem with SARS-CoV-2 and COVID-19, and what do we know about the virus. So here are some statements we've heard a lot of since the start of the pandemic, and the impositions that have been required to control the problem. So this is a new virus. In fact, it's so new, it feels like it's come from outer space. And because of that, we don't have immunity against it. It's highly contagious, so we need to be very fearful about it, very careful at least. Even if we get it and we get better from it, our immune response doesn't last. We can stop the spread of the virus if we lock everything down. And specifically for this talk, I thought I'd also I'll pose the question, can patients with CLL who get COVID-19 get better? So here are my thoughts on these issues. So I mentioned earlier that the name gave a lot away, SARS-CoV-2. It's number 2 because it's so similar to number 1 that it's really, in that sense, not a new virus. It's a mutation of the coronavirus sequence, which has created, yes, a new virus, but in fact, every year, every season, we have a whole range of influenza viruses, or viri, that have mutated and that sweep across the world. We don't regard these as being new viruses. We accept that they are part of the influenza family and have changed a little bit every year. And that's why the vaccines that we have are very important. They work, but they don't protect us to 100%. They can't. We have no immunity. Now this statement has been completely and totally debunked. It's been found that large numbers of the general population with no evidence of exposure to SARS-CoV-2 have pre-existing immunity to SARS-CoV-2. How can this be if this is an alien virus that we've never seen before? Well, as I've suggested, it is a virus that is very similar to previous viruses, and most importantly, it's a coronavirus. The coronaviri are prevalent every season, every winter season in the UK, and are the commonest cause of the common cold. And the explanation, we feel, is that there is cross-reactivity between the immunity we build up against these seasonal exposures to coronaviri to the new SARS-CoV-2 virus. It is highly contagious. Yes, it is. It's a respiratory virus. But we're beginning to learn that its contagion comes from being in close proximity with people who are infected for a period of time. You are not going to catch this virus if you go for a walk in your local park. If you go to your local supermarket that's very busy, and of course we shop in supermarkets, then it's not quite the same situation. It would be absolutely important to wash your hands, to wear face masks, and if possible, avoid that scenario. But this does not mean that we should all be locked up in our houses, even if we are someone who is higher risk. I've addressed the question of our immune response. Oh, I haven't addressed the question about immune response doesn't last. Well, actually, the president of the Royal College of Physicians releases a weekly letter. And last week, unsurprisingly, his weekly letters have focused on the pandemic since it exploded. I have tremendous respect for the president of the Royal College of Physicians. However, I don't agree with all of his opinions on the pandemic. But he himself said last week that the question of the immune response fading was a real one. But given that we estimate 44 million or more people in the world have been exposed to the virus, and we have 4 cases in the literature, 4 confirmed cases of reinfection. This is not a disease which people are succumbing to rapidly for a second time. Lockdown. How should we respond to the pandemic? Lockdown can stop the spread of the virus. Let's be very clear about this. If we reduce human contact, human interaction to an absolute minimum, we will stop the spread of the virus. The challenge, of course, for us is at what cost? And that is an art. Is it politics? It's something that's a bit more complex than saying we can stop the spread of the virus. And it would have to be a very strict lockdown to achieve that effect. And to the last point, can patients with CLL and COVID-19 get better? I noticed in the poll at the start, there were a few patients who said they'd had COVID-19 and got better, and some were getting better. I can be absolutely clear about this. The answer is yes, patients can get better. We have our own patients who unfortunately have become extremely ill with COVID-19, required ventilation in intensive care unit, and have since got better, got home, and are back on treatment for their CLL. This is not a death sentence, as I would say the impression we are given by everything we hear, that if you get the virus, then you are likely to die. That is an extremely exaggerated view of the power of this virus. Now, this is a wave. In fact, it's a very big wave. I'm not sure how well it's projecting for all of you on your screens, but just to orientate you a little bit, here is a man on a surfboard, and it is a man actually, he's not a woman. This is a different sort of wave. Now, this wave is a wave that was put up on the UK Gov website on September the 14th. And what it shows you, the number of cases let me just shrink my screen a bit. There we go. The number of cases of people testing positive over this period of time. You can see at the height of the pandemic, about 5,000 positive cases a day. And this is the 14th of September. You can see, we can see there's a second wave coming along here. 3,000 cases daily. This is, what's happened here? Let's go back one. This is the same wave as of last Sunday. Now, please don't be fooled by what appears to be the May peak has changed. It hasn't changed. It's still at 5,000. It's this peak that's changed the scale on this side. So here it was 5,000, 5K. Now we're at 20K. As of last Sunday, 20,000 people tested positive for SARS-CoV-2. Now, this is very important. The words and the data, what do they mean? I'm not convinced we know what this actually means. And why do I say that? I say that because the test detects a tiny fragment of the genes in the SARS-CoV-2 virus. It does not detect the whole virus. It does not detect a living particle. So in fact, by testing positive for this virus, if you have no symptoms, it would be impossible to know that you had COVID-19. It would be impossible, in fact, you wouldn't have COVID-19 by definition because you were not ill. And you would not know if this was someone who was recovering from an infection and this was simply dead particle of virus that had been picked up, because the test is extremely sensitive. It can detect very low levels of disease. If we add to this that here in May, the only people getting tested were patients arriving in hospital unwell. Here in September, October, we have large numbers of people being tested, many of whom have dubious reasons for being tested. So I myself am very confused about what this data is telling us. However, having said all of that, we have increasing numbers of patients arriving in hospital and ill with COVID-19 as compared to the quiet phase we had through July and August and early September. So I'm not saying we can be blasé about this at all. I'm simply trying to raise the fact that we are trying to make our decisions based on data that is very easily misinterpreted. Just a little final word about the pandemic before we get on to Q&A, because I'm hoping we will have plenty of time for Q&A. This is a 3-page article about the history of pandemics published in the most eminent medical journal in the world, the New England Journal of Medicine. And if you wish to read the thoughts in this 3 pages, you can find them using either of these bits of information shown on the slide and putting that into your search engine. I'd highly recommend it. How should we respond to the pandemic? Now, one of the questions, excuse me, there you go. One of the questions that was sent in to me prior to the webinar was a comment that patients with CLL and their families, some of them had adapted to really to lead near normal lives, while others were petrified of the fear of infection. So that dichotomy, I think, is something that we need to address at a personal level, but support people who are struggling. So here we have this intrepid surfer on this huge wave. How should we respond to the current wave that we are living through? Should we be fearful? Should we be withdrawing, isolating, locking down? Should we be trying to lead a near normal life? So I'm going to end my talk there. Some thoughts for you. If I go off screen, then you won't be able to read this. So I'm just going to leave this here just for a second for you to reflect on. And the reason I put this up is simply to say that in these troubled times, there is much that can be done to support people who find themselves in difficult situations, including patients with CLL. And I'm glad to say that the CLL support is addressing this and is in the process of trying to develop an app to help patients deal with some of the challenges of isolation and of being restricted in the current environment. So I'm going to stop there and thank you for listening, and I'm sure there'll be some comments and questions.